especially studies a lot of hospice and palliative care and communication needs as people approach end of life. And she's also an research scholar from the American Cancer Society. And she's here today to talk about shared decision-making in practice. Who here was here for some of our early shared decision-making intro talks? I got some of the background, great. And then we've had a number of applications of shared decision-making in a number of clinical contexts. And so Dr. Reblin's going to talk about advanced cancer at home and talking about everyday communication with caregivers and patients with advanced cancer, and then also understanding some variability in that communication. So with that, I'm going to turn it over to Dr. Reblin. Thank you so much. I'm excited to be here and share my work with you all. So today I'm going to be talking about advanced cancer at home. I'm a social and health psychologist, which means that I'm really interested in how people think, feel, act, and interact when it comes to their health. And I'm going to be focusing on advanced cancer caregivers and their experience with cancer with providers as well as patients. The plan for my talk is I'm going to give you a little bit of a theoretical background of where I'm coming from, and then I'll talk about a few different studies that I've been involved in. So to start out, I'm going to talk about a topic that might be very unfamiliar to many of you, which is stress. What we know is that stress, our body's response to stress is really a health trade-off. When we encounter a stressful situation out in the world, like let's say we see a bear on a trail, our sympathetic system gets activated, and that's our flight or fight response, which is really adaptive in the short term, and that our bodies kind of get amped up to get us out of that situation, right? But unfortunately, the trade-off comes where there's wear and tear over time. So for example, high blood pressure is really great to kind of amp you up and get you out of the situation, but over time, high blood pressure can turn into hypertension, which can lead to atherosclerosis, heart attack, stroke, and ultimately death, which we can all agree is not really great, right? And unfortunately, our bodies react to psychological stress the same way as we react to physical stress. It activates that same sympathetic system. So when you're sitting around thinking about all the terrible things that could be happening, your body's reacting the same way as though it's being chased by a bear. And that response isn't necessarily metabolically appropriate because it's not really getting you out of the situation, but you're still having those long-term consequences. So a lot of researchers are really interested in figuring out how we can make stressful situations less stressful. And one situation that I think is really stressful is cancer caregiving. And it's both physically and psychologically stressful. On average, cancer caregivers provide about 33 hours a week of care. And they take on more care tasks than non-cancer caregivers, including things like personal care, mobility, and household activities. And in fact, 72% of cancer caregivers are saying that they're assisting with medical and nursing tasks, things like catheter care, and they're not really getting a lot of education to be able to do this confidently. So that's also very stressful. In addition, cancer caregiving has a lot of complex emotions associated with it, like fear, guilt, and grief. So it's not surprising that a lot of cancer caregivers find themselves feeling overwhelmed and underprepared. And in fact, caregiving can impact health in that high caregiver burden and stress is related to worse caregiver health outcomes. And as you can imagine, if somebody who's caring for a patient doesn't have great health, there can be really important implications for patient outcomes as well. Fortunately, social support can help. And having supportive people in your life can help you better cope with stress and reduce its physiological impact by giving you resources to address the issue. So when we have support under stress, instead of a threat, we see a challenge. And in fact, people with better social relationships have lower levels of mortality. A meta-analysis done a few years ago now showed that people with low social support have about the same health risk as people who smoke 15 cigarettes a day and twice the health risk as being obese. We spend a lot of time, money, and energy in this country getting people to quit smoking, to eat right, and exercise. And I would argue we need to be spending just as much, if not more time, focused on people's relationships. And with relationships comes communication. Relationship quality is necessarily defined by the nature of the communication that happens within. So if you think about a relationship where somebody is mean to you or ignores you all the time, that's not going to be a very high quality relationship. And this is sort of outlined in the relationship intimacy model of couple adaptations of cancer. So in this model, a lot of the research is focused on cancer and relationship health, but essentially what it says is that relationship enhancing communication behaviors like reciprocal self-disclosure or partner responsiveness positively impacts couples' relationship intimacy, whereas relationship compromising communication behaviors like avoidance and criticism negatively impacts relationship intimacy. And both the communication and relationship factors can then impact the couple's relationship outcomes as well as psychological adaptation. So this is sort of an application of how communication and relationships impact couples, but I think it's also important to think beyond couples, beyond a caregiver and patient, because high quality relationships and effective communication are also really important to establish with providers for family-centered care. And what I mean by family-centered care is that it's working with patients and families rather than just doing to or doing for them. So kind of walking next to them. And some of that includes respect and dignity, listening to the family and the patient and honoring their perspectives, sharing information in a timely, complete, and accurate manner, encouraging and supporting participation in care and decision-making to whatever that desired level is, as well as collaboration, whether that's in policy, program development, research, education, and delivery of care. So, given that background, I'm going to talk a little bit about some of my observational work, and sort of the overarching theme for what this work entails is answering the question, what does communication look like for advanced cancer caregivers? And a lot of the work that I've done at the beginning of my career was focused on end of life, specifically on home hospice for cancer patients. And for those of you who aren't really super familiar with home hospice is a form of palliative care which is focused on quality of life delivered in the last 6 months of life. And home hospice is actually a Medicare benefit that you can qualify for. And when I started this work, I thought that hospice was basically a nurse coming to your house and sitting with you for all the time and taking care of the patient, but that's not really how it works. The family's in charge of 24/7 care, but they're supported by a nurse-led interdisciplinary team. So functionally, what happens is a nurse comes maybe once a week and brings in a social worker or a chaplain or someone else, depending on what the needs of the family are. And at the time that we did this project, there was very little research on communication in this context. So I was involved in a program project grant at the University of Utah, where we looked at nurse-caregiver communication. And this part of the program project grant was an observational longitudinal study where we captured people at enrollment in home hospice and followed them until the patient died. It was a multi-site study from 10 participating hospices in Boston and Salt Lake City. We had participants who were hospice nurses, as well as caregivers, and the hospice patients. And part of the enrollment criteria was that they were older adults. And I know that 45 doesn't seem like older, but it was. And we collected data in the home visits. We essentially asked nurses to wear a little digital recorder like this around their neck every time they came to the home. So we weren't asking them to do anything, just turn on the recorder and sort of go about how you do your thing. So we captured a lot of those digital recordings. And I'm just going to kind of give some overview sample characteristics. I'm going to talk about several different iterations of the data. But in general, we focused on caregiver and patient dyads who are older adults, 66, 68, mostly female caregivers, which is pretty standard for this population. For most of the analyses that I'll talk about, we focused on spouse caregivers. And for the most part, these were folks who had been together on average about 35 years. We also focused on nurses. These were, for the most part, middle-aged females with some hospice nurse experience. The way that it works oftentimes is that nurses work in another area of healthcare and then come to hospice, so they have more nursing experience overall. On average, a hospice visit was about 40 minutes. There was a lot of variability there, and on average, we captured about 5 visits per patient. Although, again, there was a lot of variability. When we got those digital recordings of the home visits, we used this rotor interaction analysis system to code them. And basically what this means is that we take the visit and every utterance that somebody makes, we assign a code to it. So basically every sentence for 40 minutes, we assign a code. And the codes fall into these broad categories of physical care, where you're providing information and asking questions, lifestyle or psychosocial talk, again, information and questions, and then emotional talk. And that involved distress and concern for the patient and caregiver, positive affect statements, or emotional response from the nurse, which is sort of like validation or reassurance. So when we looked at all of our visits overall, the mean proportion of visits, or the mean proportion of total talk, nurses talk the most at about 56%, followed by caregivers at 27%, and patients talked about 17% of the time. And what you can see here is the darkest part of the pie chart for each one is physical care talk, which is kind of what you would expect. If a nurse is coming to your home, you're probably going to talk about whatever physical thing is happening to you. But the next lightest color is the lifestyle and psychosocial talk. And that's more, talking about who you are, your likes and dislikes, and what you like to do, and things like that. And that was a pretty substantial proportion for all of the talk. The next lightest color is emotion. And I'm going to get more into this shortly. But what's really interesting is that positive emotion far outweighs distress for caregivers, and it's about equal proportions for patients. So I think a lot of people are really surprised to hear that there is positive emotion here, and it's not all doom and gloom. So I'm going to go into a little bit of an emotional deep dive and kind of tease out what we found in terms of both the distress and the positive emotion. So I'll start with the distress. And we really wanted to get into this to figure out what are patients and caregivers most concerned about, what's distressing to them, and what nurse communication strategies elicit the expression of distress, and how do nurses respond to distress. So we analyzed a subset of 31 visits to identify caregiver or patient distress statements, and we found 268 within those 31 visits. And then we qualitatively coded the distress statement into a specific domain of care, and then identified the coded nurse statements that fall before or after the distress statement. So you can see a nurse and a caregiver might be talking about physical information. The nurse might make a joke that leads to a distress statement from the caregiver, and then the nurse emotionally responds to that statement. So we identify the distress, categorize it, and then pick out what came before and what came after. So what is distressing for caregivers and patients? For both caregivers and patients, there was at least one expression of distress per visit, and it was usually addressing physical or psychological areas. And that was about a 50-50 split between those two. And then there were other aspects that were less common, like social aspects or spiritual aspects. When we looked at the nurse elicitation and response, what we did is we took a relative frequency of those statements before or after and compared those to the whole visit to see what was more common surrounding distress based on compared to like everything that happened in the visit. So before a patient or caregiver distress statement, we saw a lot more nurse emotional response, so reassuring or validating, and positive emotion. And those were the statistically significant differences. After the patient and caregiver distress, we saw statistically significantly more emotional response and physical questions. So patients and caregivers most frequently communicate distress to nurses about psychological and physical domains of care. And it might be that nurses are acknowledging the psychological through emotionally responding. So it's so normal that you feel that way. And follow up physical distress by asking questions to address the concern. So like, I'm really worried about this. Oh, can you tell me like what you're worried about? Would be sort of a question to get at that. And we also saw that emotion begets emotion. Nurse positive emotion or emotional response led to distress. And it might be that nurses need to open the door to emotional disclosure, and part of that might be building trust and relationship building. You don't want to necessarily walk into a room and start being like, I'm so distressed. You kind of have to build up to that a little bit. And one way to do that might be through emotion. It could also be a normalization, like we can talk about emotion during this visit, and that might be easier to do with positive emotion. So I think positive emotion was a really interesting thing for us, and so I'm going to kind of dig into that a little bit. There's been really limited empirical research on caregiver positive emotions, but what's there suggests that it might be associated with improved well-being and health during care and even into bereavement. And some of this is based on the broaden and build theory, which basically says that positive emotion broadens somebody's thought or act repertoire. So it's sort of opening the door to new experiences, and thereby can build more resources. So by going out and doing something new, you kind of get more, and that gives you more resources to then do that more and have more resources to cope with stress. So positive emotions can be really adaptive, and in fact may undo the effects of negative emotion and enhance recovery. And also, when shared, positive emotions are just fun, and they help cement social bonds. So when you're having these fun experiences with people, you become closer, and then you can kind of open the door to new things. But really, very little is known about positive emotion expression, particularly at end of life and in caregiving. So we wanted to kind of learn more about that. So again, we used a subsample of coded visits to identify positive emotion talk, and then classify that into different constructs. So we used 4 visits from 20 patient, caregiver, and nurse triads for 80 home visits. And these were the constructs of positive emotion that we were using. So connection was things like fostering relationships, building reassurance and affection. Savoring and taking joy is taking delight in life's momentary pleasures and just being open to appreciating an experience. Gratitude is counting your blessings, appreciating your life circumstances, thanking somebody. Praise and affirmation is pretty self-explanatory. Positive focus was something like optimism or encouraging others to focus on the positive. And then humor, which is, joking, trying to be funny. And that also included nervous humor or dark humor, or just kind of telling funny stories. So when we looked at the proportions of the different domains of positive communication within visits, we saw that this other code was pretty frequent, and that was just sort of like, yeah, that's good, which is sort of like positive, but like not really. And that's sort of a function of the fact that we're labeling every single sentence that people are saying. So sometimes there's going to be less strong stuff in there. But overwhelmingly, humor was the most common kind of emotion, followed by praise and affirmation, which I guess kind of makes sense if you have somebody who's trying to teach somebody else how to do something.
Yeah, just clarify. So this is on which side? The caregiver? Or
this is everybody.
Everybody.
Yes. But when we break this down
Okay.
into nice segue, the caregiver, the nurse, and the patient, we see that the nurse does the majority of positive emotion at 60%. And the majority of what she's doing beyond the other talk is this praise or affirmation, as well as humor. Caregivers have the next most amount of positive emotion. And again, aside from the other, they're doing a lot of humor. They're also doing some savoring and taking joy. And so again, this is sort of appreciating the small things in life. And then same thing with the patients. They were very similar to the caregivers, but a little bit less of the positive emotion. So nurses make the majority of positive emotion statements, mostly praise and affirmation, followed by humor. And again, I think that what's going on here is that they're really trying to set the tone and normalize the act of dying, and help the caregiver self-efficacy by sort of building them up a little bit. And again, this also goes towards relationship building. Caregivers and patients most commonly expressed humor, followed by savoring and taking joy. But when we look at what was coded, this was often dark humor, and some of that might divert from more deep emotions. But caregivers were also sort of noticing and reveling in the simplicity of life. And I think what happens in this end-of-life situation is there are some people who use this to really focus on their priorities. So we hear a lot of people saying, I'm so glad that I was able to take care of you, or I'm so glad we were able to keep you at home, things like that. And so you can kind of see these different ways that positive emotion spins out. It's like this dark humor versus this like deep. So I think that's important to hang on to for just a minute. But the implications here is that positive emotion really does happen in hospice, including humor and joking. And it might be really important to open the door to distress communication. So starting with positive and then kind of getting into the deeper emotion. But I do think we need to understand the role of humor more specifically, whether this is adaptive or maladaptive. Are you just doing the humor to distract, or are you doing the humor because you can just appreciate, like, this is just a funny situation? I also think this tells us that there is an opportunity to build on savoring small moments, and maybe there's a role for a mindfulness intervention here. But I think that this is all great to understand what's happening. But one question I get a lot as somebody who's really into mechanisms is like, so what? So what is this bias here? And so in order to answer that question, I was really interested in how emotion talk was associated with outcomes, particularly into bereavement for family caregivers. We know that caregiver depression is pretty common in short-term bereavement. And we also know that emotion expression is linked to improved psychological outcomes in other populations. We think that nurse emotional expression might be a key element of effective communication because it signals support and allows the nurse to meet the family's needs by saying, you know, I'm here for you, you're doing a good job. I think that's all really important. So in order to kind of look at how communication impacts caregiver depression into bereavement, we looked at some caregiver questionnaire data that was collected as part of another part of our program project grant that looked at depression at enrollment in hospice 6, 12, and 12 months after the patient died. We used the geriatric depression scale as well as the HADS anxiety scale. And we also looked at the caregiver nurse coded communication data, specifically the positive emotion, the distress, and emotional response. We used multi-level modeling for so that we took the communication data and predicted depression, controlling for anxiety because they're very tied together over time. And what we found is that depression and anxiety were pretty moderate at study enrollment and didn't really go down very much into bereavement. And so the blue level is the mean level for both of those things. The red level is sort of the cutoff for either suggest depression or high anxiety. And then in our depression scale, the green level is the almost always depression, just to give you a reference of like how bad is this. When we looked at the communication, there was no impact of caregiver distress on depression in bereavement. And that might suggest that distress during care is pretty normative. And so, you know, there's maybe not a lot of wiggle room there. But we did find that nurse emotional response was associated with higher depression and enrollment. And so what that tells me is that nurses might be reacting more with emotional response to depressed caregivers by trying to reassure them and bolster them up a little bit. But we didn't see any change over time to that. We also saw that caregiver positive emotion communication was associated with higher caregiver depression into bereavement, which is a little bit counterintuitive. But when we look at individual time points, when anxiety is also low, positive emotion is actually associated with lower levels of depression. So when anxiety is lower and you're using this positive emotion, then you have lower depression. So I think what's going on in this sort of complicated analysis is that the effect might really depend on how positive emotion is used. We weren't really powered to assess the humor versus savoring and taking joy, but I think there's a lot of controversy on whether positive emotion is adaptive. And I think it can be adaptive in some situations and maladaptive in others. And I think some of that is whether you're using humor or positive affect to process your emotion versus whether you're just using it as a distraction. So you all know those people who like turn everything into a joke, and you kind of wonder like, eventually that's gonna hit, right? And maybe that's what's happening with these folks. Whereas sometimes people are doing things like savoring or really appreciating like, this is just a funny situation, and that might be more adaptive. So I think we need to do more work here. So just stepping back a little bit, we did a lot of exploration into emotional expression involved in these interactions. And what's interesting is there's much more than what we typically see in clinical-based interactions. And there's a wide variety of emotion happening. The emotional context of hospice care might have an important impact on caregivers over time. But so we found all this really cool stuff. But for me as a social psychologist, I still had a sticking point, and that was the family context. All of this was really focused on either the caregiver and the nurse and the patient and the nurse. I did an analysis to just sort of get different types of hospice visits. And what we see is that it's either the patient or the caregiver interacting with the nurse. We saw that in our different types, only about 17% of the time were both the caregiver and the nurse, or caregiver and the patient interacting with the nurse. And you might say, like, oh, that's actually pretty good because the patient's declining, they're not that active, so like that makes sense. But when we look at just the patient interacting with the nurse, that's about 32% of the visits. So it's not that the patients aren't active, it's that they really are separate. So I think that this is really missing an important context of what's happening in advanced cancer care. So that led me to pursue a different project. This was what was funded by the American Cancer Society Mentored Research Scholar Grant, focused on communication at home and how couples would cope with cancer in real life. And this is upstreamed a little bit to advanced cancer because I do think that the patient decline is a real issue. And so I wanted to capture a context where the patients were a little bit more active. But this study also focused more on everyday communication, which I think is a really important factor because it provides an important context or baseline for all other communication. So if you think about couples that sort of have that jokey relationship with each other, they can say something that's like a little bit of a jab and it's okay. And sometimes it's even seen as sort of a loving thing. But if that same jab is placed in a relationship where they don't have that joking relationship, like it does not go over well. And so knowing where people are starting from can be really important for that, as well as informing interventions to figure out where couples are starting from in terms of finding strengths we can build on. There's also very little knowledge about how much couples actually talk in real life and about what, especially couples coping with advanced cancer. And most research that does exist is self-report or analog. So basically what we do is we give people a questionnaire and say, how much do you talk in real life? Circle on a scale of 1 to 10, right? Or we bring people into the lab and we say, okay, we want you to talk about something that's really stressful for 10 minutes. And however you talk about this thing for 10 minutes is how we're gonna pretend like you talk about everything all the time. So both of those methods are really useful and can tell us important things, but you can see how there might be a little bit of a gap in terms of sort of everyday communication. So because of this limited research, we were invited to put in a manuscript that I think is in press still to the Innovations in Real World Applications in Relationship Research in Cancer special issue for the Journal of Psychosocial Oncology. So I'm going to talk a little bit about what we found for that. In this study, we recruited patients and caregivers from the thoracic and GI clinics at Moffitt. These were adults and they were English and speaking and writing. Patients were stage 3 or stage 4 lung cancer or GI cancer with relatively high functioning and a prognosis of greater than 6 months. And again, we were sort of upstreaming from hospice where these are still folks undergoing active treatment. Caregivers were cohabitating spouses who self-identified as providing at least some care. And again, this was a naturalistic ambulatory study where we had those little digital recorders and we recorded continuous caregiver and patient communication, as well as caregiver ambulatory blood pressure during waking hours. And I'm not going to get too much into the blood pressure part, but basically it's a blood pressure cuff that connects to a little box that you can wear around and it takes a blood pressure reading throughout the day. So we asked participants to gear up with this stuff and participate on a day when they plan to be home together, which functionally turned out to be about mid-morning to bedtime. And basically what we did is we had folks fill out some questionnaires, including demographics, relationship quality, cancer concerns, and burden. We did do one of those analog discussions where we asked them to talk about something stressful, and then we just asked them to go about their normal day with the recorder on, their day in the life, and then we, at bedtime, they put everything in a box and mailed it back to us. And we did end up doing a debriefing interview with the caregivers afterwards just to kind of get their perspective on caregiving, communication, and their relationship. I'm mostly going to focus on some of the questionnaire data as well as the day in the life stuff. So we took those day in the life recordings and we coded the data. Basically, coders identified and categorized communication based on that intimacy model that I talked about in the beginning. that was really focused on, a lot of the research there has been focused on relationship talk and cancer talk. So we really wanted to figure out how much of those kinds of talk people were doing. So we were very liberal with how we coded for relationship talk. Any feelings about each other, whether they were positive or negative, relationship history talk. We were able to capture kissing, even though we just had audio, because sometimes you can hear that. So I was really stoked about that. We also captured cancer talk, and again, we were very liberal. So anything talking about treatment, medication, feelings about cancer, symptom talk, talking about appointments or what might happen next. And then anything else that they talked about, we put in this other bucket. And this was anything else with at least 3 exchanges, so patient, caregiver, patient, or more than 90 seconds. Oftentimes this was sort of just chit chat and household tasks, but we did the exchange thing because we didn't want like, hey, where's the remote? It's not enough. Conversations were broken by 30 seconds or more of silence. 20% of our recordings were double coded, and we got pretty good reliability. These are just some examples of the communication domains. So for relationship, I love you. Why do you all have to argue with me all the time? For cancer, my brain is being cooked with radiation. When's the last time I took my pain medication? Other talk, a lot of people talked about food a lot of the time. People also gossiped about their neighbors a lot. And then there was like a lot of household logistical stuff. So in the study, we had 83 heterosexual couples, mostly Caucasian, and patients were a little bit more likely to be male and older than caregivers. Couples had been together on average about 35 years. When we looked at the psychosocial questionnaires, and this is sort of a messy slide, but basically patients and caregivers were pretty anxious and distressed, like sort of a moderate level. Caregivers were actually significantly more anxious than patients were. When we looked at relationship satisfaction, people had pretty high levels, and the correlation between the patient and caregiver is also very high, and no real differences there. When we looked at burden, these are pretty burdened caregivers, and in fact, the stress burden is kind of, the average level is higher than the high level cutoff. So, you know, this is a pretty intense situation here. When we asked people what their top cancer concerns were, it's basically a check of things that are common, and they say whether it's not a concern, somewhat a concern, or a severe concern. So all participants reported at least one severe concern. Caregivers listed more severe concerns than patients, but there was very low dyadic concordance. So you can see there isn't a lot of agreement about what the patient's top concern is and the caregiver's top concern. The patients were really, their top concerns focused on lack of energy, difficulty doing physical activity, not feeling sexually attractive or having less sex, worry about cancer and pain,
When you say lack of energy, is that lack of energy that the caregiver has or lack of energy that the caregiver thinks the patient has?
Good question. We left it open, whether they were talking about the patient, whether they were talking about the caregiver, or the perception, either way. So that is one limitation to the data. But we just asked, like, you know, what's worrying? Check this off. So without specifying. Good question, though. For the caregiver, their top concerns were worry about cancer, lack of energy, feeling overwhelmed, difficulty sleeping, and difficulty talking with a partner about end of life. So again, we don't know if, for example, feeling overwhelmed was the caregiver themselves were feeling overwhelmed or they thought the patient was. When we looked at our observational data for the audio recorded communication, on average, our length of recording was about 10 hours. So there was a pretty wide range there. The median total amount of talk within that recording was about 1.5 hours. Again, pretty wide range. And on average, people were having about 36 unique conversations between the patient and the caregiver, lasting about 7-ish minutes each. Again, a lot of variability. When we saw how much cancer talk, there was about 1.5 minutes in the entire day. You can see there's pretty wide variability, but 22% of couples didn't talk about cancer at all. When we looked at relationship talk, people were talking about that on average about 30 seconds in a day. 54% of couples didn't talk about their relationship at all. And then everything else was sort of that other talk. There was no difference between patients and caregivers, and no significant relationship between the amount of total observed communication and demographic and health factors. And what was interesting is that higher patient but not caregiver perceived relationship satisfaction predicts more time talking about cancer, and more perceived caregiver burden predicts less time talking about the relationship. So there's sort of this interesting cancer relationship crossover happening. So the majority of communication in these couples happen outside of the cancer and relationship domains. And I think what's important to remember is that life goes on for these people. I think sometimes you think like you have this super serious life-limiting diagnosis, it's gonna take over your life, and that's all you're gonna talk about and all you're gonna think about. But for a lot of these people, it's not the biggest thing that's happening for them. They still need to gossip about their neighbors and figure out what they're gonna eat for dinner. And so I think it's really maybe kind of nice that not everything is cancer. But some of the variability that we see and the small amounts might be due to the timing and the cancer relationship trajectory. So when we recruited for this project, we weren't saying like we want to capture people right after diagnosis. We just kind of took anybody who fit our inclusion criteria. So some of the people might have been right after diagnosis and talking about cancer all the time. And if you remember, a lot of these folks on average have been together about 35 years. So maybe talking about their relationship is kind of old news, and so they don't need to talk about it. But that being said, sometimes, they were planning their kids' weddings, or, somebody was having relationship trouble. And so that might kind of spike up the relationship talk a little bit, right? So I think we have to keep in mind that the context is really important. We don't know what else is going on with these folks. And some of the variability might also just be due to people's communication styles. If you've ever been on an airplane, you know that some people are just talkers, and some people just aren't. And so figuring out where you fall on that trajectory might predict how much you're going to talk about whatever is going on in your life. I think these results also tell us that relationship and cancer are really tied together. Many top cancer concerns are actually relationship focused, like talking about sex or talking about communication. And I think it was interesting to see that patient relationship satisfaction predicted cancer talk. And I think what's going on there is maybe the patient thinking that they're in sort of a safe relationship can open up more cancer talk. I think a lot of what's going on is patients don't want to burden the caregiver unless they feel like it's okay. I think that that's a big hot point, so that's interesting to think about. And then kind of conversely, caregiver burden predicts relationship talk. And so I wonder what's going on there, and whether it's high caregiver burden lowers the bandwidth for relationship talk, or maybe it's sort of a third variable thing where people who have lower relationship quality have higher burden, and they also just want to talk about their relationship. So I think there's more exploration that can be done there. In terms of limitations and next steps, for this study, it was mostly verbal communication, although we did capture kissing. There's a lot more that could happen. And I think especially for relationship talk, nonverbals can be really important. So if you can kind of think about like a smile or sitting next to somebody and holding their hand, like those are really meaningful things that might actually mean more than just saying I love you sometimes. And also for this, we captured what couples discussed, but not how they were discussing it. So we're currently analyzing this data, both with traditional human coders who are sort of listening and making decisions about what's happening, but also with behavioral signal processing and acoustic analysis, which is sort of like machine learning and picking up pitch and tone and things that is a little bit more difficult for humans to pick up on. But I think some of those unconscious things we might understand them, but not be able to identify them. And I think that's an interesting area to pursue. Also, these findings haven't yet been linked to well-being, so we're currently analyzing that, and I think we have a lot to say about both patient and caregiver well-being, but also caregiver cardiovascular health and patient mortality. So I think that'll be interesting to look at. But I think one of the big implications is the need to identify what the right amount of communication is. And some of that might depend on the couple, and some of that might depend on the stage that they are. So it might be really helpful to talk about cancer all the time right at diagnosis, but if you're still talking about it 6 months later, like something might be up, right? And so we don't really know what the right amount looks like, but there are a lot of established interventions out there that have sort of this communication component to it. And so without knowing like what exactly that looks like, we need to think more about what those interventions look like. Also, the intimacy model that I talked about before was really built on cancer and relationship domain talk. And so we need to do more research to identify if that framework still holds, if what people are most talking about is other talk. Can we apply what we find there to the model? And then also, because we didn't see a lot of communication about cancer or the relationship, some of those interventions that I talked about, some of them have really great communication skills aspects to them. But if couples aren't naturally talking about those things, they might be needing a cue to kind of open the door like, oh, we should talk about this. Because if you never engage in the skill, learning the skill doesn't really matter that much. So I think there's more work to be done to build these interventions to how people actually communicate and live, for example. I also think that there are a lot of missed opportunities. A lot of the patients in our sample really were at end of life. Even though they had a 6-month prognosis, a lot of them died within a few months of participating in our study. And I think at end of life, we really need to be thinking about planning and benefit finding, meaning making, because those are things that are really beneficial for the experience at the time, but also for caregiver bereavement outcomes. And I think one thing that I'm thinking a lot about now is encouraging meaningful discussions and promoting the use of more positive emotions, because I think particularly if you're thinking about sort of the gratitude and savoring, those are really the building blocks of resilience. And I think that that can be really useful into bereavement. And we know that some couples already go positive as a means to discussing stressful topics. So how can we build on that and identify those folks and teach that to other people? So in terms of future plans for intervention research, I think it's really important for me to identify critical periods for family caregivers and provide them psychological tools to help cope, whether that's facilitating communication between the caregiver, the patient, the provider, or even the broader social network. Reframing things to focus on opportunities or positive aspects of their experience, or building on existing sources of strength. A lot of people have talked about how their relationship is really strong and they use that to help them get through the experience, and as well as their broader social network. So really kind of focusing on that. And I think also a lot of my work has been done in cancer because I'm at a cancer center. But I have been involved in some research in stroke and spinal cord injury, and I think a lot of these tools can kind of expand out to other disease processes and situations. And so I think it's really a nice thing to think about how these mechanisms can be applied in other places. So with that, I'd like to thank you all for being here. I'd like to acknowledge and thank my team. Many thanks to the participants who have made this happen, as well as the funding. And I'm happy to take questions.
I may have missed this, but in the first study, what was the relationship between the caregivers and the patients?
Yeah, for the most part, they were spouses in most of our analyses. But so it was a little bit interesting because we recruited broadly. I would say probably about 65% were spouses, but most of the analyses that we did were on spouses just to kind of make the relationship a little bit more standardized. But we're working on some analyses looking at patient-child relationships and how that might compare to spousal relationships. So TBD. Yeah.
In the very beginning of the presentation, you had talked about the caregiver and the nurse and positive communication and stress communication elements. It made me think of that type of communication coming from the nurse. Was there anywhere in this work where you looked at that type of interaction being supportive of the nurse?
That's a really interesting question, and we haven't looked at it, but it's definitely something that we've thought about in the broader context about nurse burnout is a huge issue. Anecdotally, I will say that a lot of the caregivers are very appreciative of the nurse and are pretty vocal about like, I couldn't do this without you and things like that. And we did do a qualitative study where, so one of the parts of the program project grant was focused on bereavement, and they had interviewed a lot of caregivers, and they were saying that it's really difficult for them because they develop this relationship with the nurse and then it just sort of ends when the patient dies, and that's very challenging for them, but it's also challenging, I think, for the nurses. So I think that's definitely a phenomenon, but we haven't really gotten too far into it.
Did you find any work from a researcher that is at the University of Minnesota who did something very similar, but it was more on outpatient home care and the Omaha model for terminology and tracking of types of verbiage that was used to indicate care? It's Dr. Karen Munson. She has some data. I was looking at your charts, and the way you put your charts together, especially the coloring of the lines, is very similar to the type of word utilization that occurs between a home health patient and a nurse practitioner.
Interesting.
So just something, she's got some amazing work out there related to the Omaha system and verbiage. So
Yeah,
just
I'll have
throw
to
it
look
out
into
there.
that.
She's awesome, by the way.
Awesome.
Yeah, she's
I
really
like good
cool.
people. Thanks.
So for the reasons of capturing data or delivering interventions, do you guys have plan to utilize technologies such as Alexa or Google Home?
Yeah, I think that would be really interesting. So the folks that I work with who do the behavioral signal processing have sort of their own methods of data collection, but it's very clunky. If you want to get the data, you have to put in like a bunch of different microphones and like blah. And I think in the future, once the technology gets a little bit better, and I think also sort of the proprietary interface is a barrier, but I think, in the next few years, it would totally make sense to just put in an Alexa and some dots and call it good. But I think that they're still working on how to make that work and validating it and actually being able to get the data out of it. But it's definitely something that I'm thinking about and kind of paying attention to.
And also delivering maybe some interventions.
Yeah, and I think a lot of times people are like, you're recording these people, like, isn't that creepy? But like, I think that that's starting not to be as creepy now that we have Alexa and Google, and we're all like, Alexa, what time is it? I'm sorry if anybody's phone just went off. I think just how people think about things has shifted, and so I think maybe 5 years ago, having a thing in your home being like, you should take your medicine now would be like super, but like now it's becoming, like that would be really helpful and I would appreciate it. So I think it's also a cultural thing that we need to ride that way.
Yeah, Alexa could say something like, could you rephrase that in positive?
Really negative.
Exactly.
Make a joke, maybe. This is really a question about your research. I was just thinking about your slide where you talked about like meaning making and end of life and like what these kind of studies can do for caregivers. Have you considered, especially for implementing interventions, returning recordings to the caregiver the fifth?
Yeah, that's something that we've kind of gone back and forth on, and it's definitely something like, so in our study, we took the blood pressure readings and people really wanted those and they asked for those, but they never asked for the recordings. And we didn't initially think about it, so it wasn't in our IRB and nobody asked for them. But I really think that some of that might be really good. It's just sort of an ethical thing, and I think like returning results is always sort of a thing, like especially if like something negative happened. I'm not sure.
That's why I was thinking more the intervention.
Yeah.
Like if there was a primed conversation that was, I was just thinking about meaning making and what maybe caregivers could take from that.
Yeah, I think that's definitely like in the back of my mind and something to think about for sure in the future.
So in the minute and a half that they spoke about cancer, what types of things did they talk about?
Yeah, that's a good question. A lot of it was just sort of like very logistical, like when was the last time I took my pain medication? Did you take your pain medication? Oh, you need to call the doctor and make an appointment for blah. It very infrequently was sort of the like existential stuff that you think people should be talking about. So I don't know. And again, it could be that they've already had those conversations or they're gonna have those conversations, but yeah.
Or that happens at night?
Yeah, that's the other thing that I think about is like they took everything off at bed, but when they went to bed. But I think like for a lot of couples, like going to bed, you have those conversations of like, this is what I'm really worried about when the lights go off, and like, or when you wake up or something like that. And so I don't know that society's ready for like the microphone at the bedside yet, but maybe one day.
I'm not as familiar with that, audio data collection and coding. What's the time required to do something? I mean, it's
A lot.
hours and hours.
Yeah, so the recordings were on average about 10 hours, and once coders got trained, they could get through it in about real time-ish, but it takes a while for people to get trained. Basically, I applied for this grant, and everyone was like, you're never going to be able to do it. And I was like, watch me. And I was like, and now I'm like, yeah, I probably shouldn't have done that. But I think we do need to collect this data so that we can get to the place where we can do more automated things. So there's like this human in the loop coding method where you have human people create sort of a baseline data set, and then machine learning happens, and then the person kind of corrects the machine learning, and then there are different iterations like that, so it's less time, but it's still very time intensive. So that's why there hasn't been a lot of that research.
Well, thank you.
Thank you.